Hi everyone, I'm Dr. Ramesh Venkatraman, Senior Consultant in the Department of Critical Care Medicine, Apollo Hospitals, Chennai. Today I'm going to be talking about the pharmacokinetic and pharmacodynamic principles that dictate the antibiotic use. So we'll start with the basics of PK/PD. What exactly is PK and PD? We will talk about some relevant principles related to pharmacokinetics. I will also go through some pharmacodynamic principles. Other considerations that we need to take over when we are going to prescribe antibiotics in a clinical setting, and with those ideas I'm going to conclude my talk. So talking about PK/PD, what exactly is pharmacokinetics? When we give a medication to any patient, the concentration of the medication over a period of time is what we call as pharmacokinetics. In effect, pharmacokinetics is nothing but what our body does to the medication or the drug. In this situation, it is the antibiotics that we are going to be talking about. What then is pharmacodynamics? Once an antibiotic reaches a certain concentration, the effect it exerts on the human body or the relevant target is what we call as pharmacodynamics. So in essence, pharmacodynamics is nothing but what the drug does to the human body. So in effect, pharmacokinetics is what the body does to the drug, pharmacodynamics is what the drug does to the body. With that brief interlude, we'll go a little bit in detail towards the significant pharmacokinetic principles. The first principle I want to talk about is volume of distribution. We will talk about clearance of a drug. We will talk about the half-life of a drug, which is determined by both the volume of distribution and the clearance. The peak drug concentration is very simple. As the name suggests, it is the highest concentration of the drug in the human body. Minimal drug concentration is the lowest drug concentration in the body. Area under the curve is nothing but the concentration of the drug in the blood over a period of time. In these variables, we are predominantly going to be talking about the volume of distribution, clearance. Those are the two important pharmacokinetic principles that will dictate our use of antibiotics in any given patient. What is volume of distribution? It is the relationship between the total amount of drug in the body to that of the plasma concentration. For example, if I have a drug, I'm giving whatever route, oral route, IV route, whatever route I give, if all the drug is only inside the vasculature or the blood compartment and there is not much diffusing out of the blood compartment, then we would say the volume of distribution is small, because the total amount of drug in the body and the plasma concentration will almost be equal or very minimal. Therefore, we call it as a low volume of distribution. On the other hand, a drug diffuses across compartments and gets into the tissues, therefore the plasma concentration is lower, we would say volume of distribution is larger. In effect, what is the overall body amount of drug divided by the concentration of the drug in the vascular compartment? This is what we call as the volume of distribution. So let's assume that we are injecting a patient with 5 milligrams of a drug, as you see in this slide. And 1 hour afterwards, I measure the plasma concentration. I find that the plasma concentration is 1 milligram per liter. Remember that we had given 5 milligrams of dose of the medication, but when I measure in the plasma, I get 1 milligram per liter. Indirectly, it means that my total volume of distribution is 5 liters, because for every liter I have 1 milligram, I have given 5 milligrams of the drug, therefore the total volume of distribution would be 5 liters. In effect, if your plasma concentration is higher for any drug dose you give, then the volume of distribution becomes smaller. If the plasma concentration is lower for any drug dose you give, it means more and more drug is outside the vasculature, outside the blood volume. It has gone into the interstitial area and the tissues, and therefore the volume of distribution would be higher. There are certain conditions where we would desire a lower volume of distribution. There are certain conditions where we would desire a higher volume of distribution. We need to understand that this volume of distribution will determine the loading dose of a drug that we give, because for us to reach a particular plasma concentration, we have to give a certain amount of dose of the drug so that it reaches adequate concentrations, and for that we need to understand the volume of distribution. Hope this is clear. What are the factors that determines volume of distribution? One is the pKa, which is just a chemical properties of the medication in terms of what the pH in the particular area is compared to the pKa, the dissociation pH of that particular drug. We won't go into the chemistry of that. It also depends on whether the drug is predominantly hydrophilic or lipophilic, as you will see in the later slides. It also depends on how much of the drug is going to bind to the proteins, and whether it is going to be binding to the proteins in the plasma or is it going to be binding to the proteins in the tissues. Volume of distribution will change with age. As people get older, their intravascular volume goes down, therefore the volume of distribution would go down, and our drug dosing has to be appropriate for the age of the patient. Women generally have more water in their body, therefore their volume of distribution would be higher. They also have more fat, therefore their volume of distribution would be higher. This can be changed in states like pregnancy, where we need to pay even more attention to the volume of distribution prior to giving a particular dose of the drug. Disease states like end-stage liver disease with cirrhosis and ascites can tremendously change the volume of distribution. Sepsis, as you will see, is very important for us because we are talking about antibiotics here, and it can change the volume of distribution by several mechanisms, as I would allude to in the subsequent slides. Like I said earlier, this understanding of volume of distribution will dictate the loading dose we give. If somebody has acute renal failure, we may have to cut down the dose because the clearance may be lower. On the other hand, their volume of distribution may be higher because they have more water retention in their body, and this will interplay in terms of deciding how much drug to give to that particular individual. The next concept we will talk about is clearance of drug. What exactly do I mean by clearance of the drug? It is the volume of blood cleared of the drug per unit time. Drug can be cleared by metabolism, drug can be cleared by renal excretion, it can be cleared by hepatic metabolism. Whatever it is the amount of drug cleared per unit time is what we would call as clearance. It is the irreversible elimination of the drug by the body, either by excretion or metabolism. This would obviously dictate the maintenance dose. Remember that earlier we talked about the loading dose that is determined predominantly by the volume of distribution. If the drug is cleared faster, we may have to give additional maintenance doses more frequently. On the other hand, if the drug is not cleared as fast, then the maintenance dose frequency can be reduced. The amount of maintenance dose also would depend on the mechanisms of clearance and how effective the clearance is for these drugs. The clearance can be altered by protein binding. If a drug is bound by protein, it is unlikely to be excreted by the kidney because it doesn't get filtered as much. It can be affected by the cardiac output. If the cardiac output is very high or very low, the renal blood flow can change, the hepatic blood flow can change, and therefore we can have altered clearance of drugs. If we have a significant end organ dysfunction like severe renal failure or hepatic dysfunction in a patient with septic shock, the drug clearance can be severely hindered. If the patient is on dialysis, dialysis would be removing certain drugs, especially if they have low molecular weight, water soluble, and have small volume of distribution. Those drugs will be ideal for removal through dialysis, and therefore we may have to supplement the doses of antibiotics for patients who are on dialysis. If the patient is on extracorporeal membrane oxygenation, then the volume of distribution increases, and we need to be cognizant of that fact when we give doses of medications to patients on ECMO. Finally, techniques like plasma exchange, which basically remove a lot of plasma and then exchange it with fresh plasma, can remove drugs even if they have high protein binding, because when we remove the plasma, those drugs are going to be removed, and therefore we may have to supplement higher doses in those patients who receive plasma exchange. An important factor that we need to understand in critical illness is something called augmented renal clearance. It is important to know about it because we need to be able to suspect it in certain patients and dose our drugs according to that. So what exactly is augmented renal clearance? Let's say somebody is critically ill with sepsis in the ICU. Certain things happen to their physiology. For example, they have a systematic inflammatory response syndrome where it causes vasodilatation and increase in cardiac output because of the vasodilatation. These two will augment the renal blood flow and may increase the preload of the patient. I would be resuscitating the patients with fluid therapy. Therefore, I will increase my intravascular volume, which will increase my volume of distribution. There can be capillary leak, more interstitial edema, higher volume of distribution if it's a hydrophilic drug, and at the same time, I can also increase or decrease my renal blood flow depending on my hemodynamics. I use vasoactive agents like norepinephrine, which can squeeze the blood vessels, increase the mean arterial pressure, and alter the blood flow to the end organs, including the kidney and the liver. The interplay of these things can essentially increase or decrease the renal blood flow, increase or decrease the preload, increase or decrease the renal reserve, and therefore can cause increased glomerular filtration. When I talk about augmented renal clearance, most of these mechanisms lead to increased renal blood flow, increased glomerular filtration, increased clearance of the drug through the kidneys. Simultaneously, as the cardiac output increases, the tubular secretion of these drugs can also increase. Therefore, the renal clearance of these drugs can increase tremendously. This will in effect need a much higher doses in patients suspected to have augmented renal clearance. But how would I know that somebody has augmented renal clearance? As of now, we go by our clinical risk factors of augmented renal clearance, and if these features are present, we assume that this patient has augmented renal clearance for all practical purposes. What are the risk factors? If people have increased cardiac output, as I said, in a resuscitated critically ill patient who is septic with high cardiac output. Vasopressor support can squeeze the blood vessels, increase the preload, and cause increased cardiac output. It is likely to be seen in young people who are otherwise healthy, males. Somehow patients with trauma seem to have an augmented renal clearance compared to other diseases, and especially if the patient is not very sick, then one should suspect augmented renal clearance in such patients. Understand that augmented renal clearance will increase the drug elimination through the kidney. Therefore, our drug concentrations become lesser. We may need to give higher doses or more frequent doses of antibiotics in these patients to counter these effects. I mentioned earlier hydrophilic versus lipophilic nature of the drugs. Hydrophilic, it gets attached to the water. Lipophilic, it gets attached to the fat in the body.